Hello, welcome. We'll give everybody just a couple of minutes here to join and we'll get started in a minute. Thank you. All right. Let's see. I think we'll get started here. We'll let people continue to trickle in here, but thank you for joining today's webinar, co-promoted or co-presented by Gardner Law and JDL Access. It's called Guardrails That Work, Practical Reimbursement Rules for the Field. And it'll be myself, Amanda Johnston, Mark Gardner, and Kim Norton. And just a couple housekeeping announcements before we get started. This program is being recorded and we will share it afterwards. If you have questions, please use the question function, which is on the little tab on the GoToWebinar control panel. We'll hopefully have time at the end for questions. Otherwise, feel free to follow up with us after the program and we're happy to connect then. This program is eligible for 1 CLE credit in Minnesota, and we will be sharing information about that after the program. Also, we will send out a short survey after the program, and we really would appreciate it if you could take a few minutes to just fill that out. It helps us gather feedback and improve future programs. So thank you in advance. And Mark, if you want to kick off the agenda and you can introduce yourself, and then I'll take it back when you're done.
Thanks, Amanda. I'm really excited. Seeing lots of familiar names in the attendee list here, and welcome. So we'll go through some brief introductions. I think a lot of you that have joined today know us already. We'll get into this topic of why reimbursement support is essential, and I won't take away Amanda's thunder on that, but really, these programs, these reimbursement support programs touch all the major bodies of law that manufacturers tend to run afoul of if they don't have controls in place. So Anti-Kickback Statute, False Claims Act, of course, HIPAA, even the Food, Drug, Cosmetic Act. So we want to be really careful with these programs. Good news is these support programs are recognized by AdvaMed as legitimate, and it's very common to support patients in their access to medical technology. So we'll get into that. Kim will talk a lot about program models and operations design, so you can really see under the hood. We'll talk about sales and marketing and reimbursement guidelines. You really want your sales team to be equipped with sound information, but know when to hand that baton off to the reimbursement experts. So we'll get into do's and don'ts and hopefully tell some stories along the way. And we invite your questions. So if you're able, go ahead and post questions in the chat box and we will get to those as much as we can. A little bit about Gardner Law. We work with medtech, pharma, biotech companies, food companies even. They really don't have to worry about reimbursement as much, unless maybe they're medical food or something. But we provide counsel to clients on regulatory, compliance, privacy, commercial, and litigation matters that relate to the laws I mentioned a minute ago. And we can go to the next slide. A little bit about me. I've worked, I think I have to update that, 25 years in healthcare. I think it's 27 now, but it gets less cool too as that number grows to amplify that. But love this space. I've worked in healthcare my whole career in biotech and medtech. And I teach at local law schools and at Carlson. And I co-founded JDL Access, with what I would consider the leading minds in reimbursement, medtech, reimbursement, especially in the industry. So very excited to co-present here. Amanda and I are very excited to co-present with Kim, who is CEO of JDL Access. And I will hand it over back to you, Amanda.
All right, great. And I'm Amanda Johnston, a partner at Gardner Law. Been in the space my entire career, like Mark, I love it. Been in compliance, regulatory, legal, at a variety of medical device companies. And I've been at the firm here for almost 7 years. And I will pass it over to Kim to introduce herself.
Great, thank you both. I'm so glad everybody's here. Happy to be here myself. I think I have you just a little bit beat, Mark. I think I'm at 30, but I'm stopping there. I'm not counting anymore. I have been in and out of various either medtech companies or consulting my whole career in reimbursement. And for the last year and a half have been leading JDL Access, which we'll talk a little bit more about what we do. But I'm just glad to be here with two legal experts in the field. Here we are, JDL Access, established, as Mark said, co-founded with a number of people who've been working in this sector for a very long time, with the goal of providing integrated reimbursement support, patient access to the medtech industry. Really, as we see barriers continue with payers to emerging technologies, I think it's become more and more urgent to be able to support innovative tech with patient access programs, payer access programs, et cetera. So that is the crux of what we do, and I'm looking forward to talking more about that today in terms of compliance, especially.
Great. Thanks both. So with that, I'm going to get started by just touching a little bit on, Mark had mentioned that the reimbursement support program space really touches on so many areas of law. So it is kind of in the intersection of a lot of the high-risk legal framework that we have in the healthcare space. So it does, really require careful navigation of all of these requirements. And we'll dig deeper into each of these areas just to unpack that a little bit. So we have kind of the fraud and abuse piece, which is at a federal level, at least, the Anti-Kickback Statute and the False Claims Act. So these programs could implicate both of those legal frameworks. Under the Anti-Kickback Statute, just as a refresher, it is illegal to provide anything of value to influence the purchase, prescription, or use of items that are reimbursed by federal healthcare programs. So in this case, typically we typically would recommend safeguards in place to make sure that the reimbursement support program does not go so far as to become something of value or remuneration. And that's, one of the safeguards we'll talk through a little bit more later about how we recommend or how we operationalize those recommendations. And then we also have the False Claims Act, which if there is the kickback violation, there's always going to be a False Claims Act violation. But in this area, there also is a False Claims Act risk, because if a company is inducing a false claim by providing incorrect or inappropriate reimbursement support, that can itself result in False Claims Act exposure. And each of these areas of law, I'm sure you've watched the headlines and the enforcement actions that come out. They really result in significant penalties, up into the millions and even the billions, and carry exclusion as a penalty, which means you're really excluded from participating in federal healthcare programs, which essentially is a business ender. So those are the two key, federal fraud and abuse laws that are at issue here when we're talking about reimbursement support programs. Some states have their own versions to protect private payers. So it really is not just a Medicare, Medicaid risk. It can also extend to commercial payers as well. And then FDA, from an FDA perspective, just at a high level, so FDA regulates how drugs and devices are manufactured and promoted. So where the FDA risks may come into play here is if a reimbursement support program, for example, is being used to facilitate, or even, hopefully not, but facilitate, it could be viewed as off-label promotion. So one of the safeguards we often recommend for companies is to exclude off-label cases from the reimbursement support program, because there is a gray area there in terms of the FDA could, or the DOJ could make the argument that if you are supporting or facilitating off-label uses, that you are essentially promoting the off-label use of the product. And again, that ties back into the False Claims Act, because if you are off-label promotion is a theory of violating the False Claims Act, the government would make the argument that had you not been, promoting the product off-label or facilitating off-label use, they wouldn't have gotten the claim and they shouldn't have paid it. That's kind of the theory of liability that the government would approach this area with. So those are kind of the three big buckets. Privacy and HIPAA and state privacy is another major bucket. Obviously, these programs deal heavily with protected health information if they're working with a provider and a patient. So PHI under HIPAA would include patient identifiable health and payment information. Patient access and reimbursement support programs obviously frequently involve PHI. So if you are submitting prior auths or supporting the appeals process, or trying to get coverage verification, obviously involves patient information and the flow of patient information potentially between entities. So this is definitely an area of high risk for these types of programs. So from a compliance perspective, obviously there's going to be some considerations when approaching, or thinking about building one of these programs, or even just monitoring these programs once you have it established. Really, there has to be a HIPAA compliant basis for using and sharing PHI. So whether that's a business associate agreement or a patient authorization, it's very fact-specific analysis. But that's one of the key safeguards here, is really making sure that you're following HIPAA with the use and distribution of PHI. These programs require companies to implement and maintain robust privacy compliance programs. So that would include privacy and data security safeguards. And we'll talk a little bit more about kind of the different models and structures. But either way, whether it's in-house or you're using an outside third party, there's going to have to be a privacy program with security safeguards in place to make sure that you are following all applicable privacy rules, including HIPAA and any state laws. I already mentioned state privacy laws. There may also be institutional or facility policies in place regarding the use of these support services. So just another kind of angle to consider. One kind of trend that we've seen coming up recently, and I'm sure Kim can speak more about this as well, but payer portals are becoming more of a common thing. So logging into payer portals, electronic transactions through a portal, they're becoming more and more common. And so a question that we've got in the past is kind of the access to those payer portals and how HIPAA applies to that. And because it's so role specific and fact specific, it really depends on how the program is structured, how the contracts are in place, how the entities are working together or not. We aren't able to give, a great kind of do this, not that. Really recommend consulting with privacy counsel just to make sure that you have kind of all your, you're able to access the information in a compliant manner so that you can, facilitate patient access to the therapies and continue with the compliant program. And so just talked about some of the kind of higher risk areas that kind of all intersect over reimbursement support programs. One of the key pieces that we're going to be kind of honing in on today is the separation between sales and commercial and reimbursement. So why is it important? So having that separation is really a key safeguard to mitigate risk from an Anti-Kickback, False Claims Act, and FDA perspective. Really keeping the roles separate. So, wearing your reimbursement hat or wearing your sales and commercial hat. The sales team, they drive revenue, they drive demand, they're selling clinically, they're selling the product. Reimbursement support, on the other hand, their role is to facilitate patient access to therapy. Anytime that we're blurring the lines or the roles between those two areas, that's where we can get Anti-Kickback Statute risk, False Claims Act risk, and FDA promotional risk. So really the key drivers in this space is if sales or commercial has influence over any coverage, coding, or documentation. That would blur the line into that kind of intentional separation, which creates risk that commercial is potentially influencing kind of the claims that would be submitted to federal payer or federal healthcare programs, and that could be a False Claims Act issue. The perception that reimbursement support is being used as a sales tool. So from an Anti-Kickback Statute perspective, I had mentioned that we really want to be careful to make sure that we are framing our reimbursement support to really help patients access therapy. It should not be positioned as a sales tool. It should not be positioned as a value added to the provider or the practice. We just want to make sure that that scope of separation is very separate when it comes to kind of why reimbursement and sales should be kept separate to mitigate risk. An area where we see a lot of risk, and we'll talk a little bit more about some areas where we see missteps, but inconsistent or undocumented handoffs between the sales and reimbursement teams, and really kind of blending of those roles. And that is where we see a lot of the risks arise. So really the key takeaway here, reimbursement support exists to support patient access, not to close sales. And anytime we're blurring kind of the lines between those two functions, that's where we might see some of the risk arise.
I think you make some great points there, Amanda. But the core principle at the bottom there really resonates. They're not there to close sales. If you think about why the government tolerates reimbursement support at all, it's because they know that it's difficult for patients to get access to technologies that are new, that don't have 10-year clinical data, and that payers are reluctant to pay for that reason. So to the extent reimbursement support can facilitate conversations, provide accurate information that helps the payers see the light, if you will, and say, okay, we should pay for this because it's right for our beneficiaries and we're going to maybe save money in the long run. Those are good reasons. We just need to be careful with that message because we're ultimately getting involved tangentially in the coding process, right? Like we're not telling people what to code. We're not making submissions without knowledge of the providers. They have to approve all of that. But we are influencing that process. And so with that influence comes risk. And that's, so it's a great point that we have to be really careful that the information is accurate and it's not these reimbursement support experts and functions like companies like Kim's, they're not there to close sales. They're there to support the process and support that patient and their journey to getting access and ultimately getting better. So just wanted to add a couple points there that I think this is a really important slide.
No, that's a good add. Yeah, thanks. Go ahead, Kim.
Yeah, I was just going to say to that point, Mark, that what we see works well with the sales team is that they inform the providers that this support service exists and then hand it off. And we enroll the provider in our program and then the sales team is sort of out of it at that point. The provider knows that we exist. They know that we can support patients as they come through their door and need a particular new innovative technology. And they make the key here is that the provider makes the decision to use the technology separate from that. decides this is the right clinical treatment for a patient and then enrolls the patient in the program. So sales is completely out of it. The existence of the program doesn't influence the provider making the treatment decision. They make the decision and then hand the patient off to us. So
Right.
I think, as long as that process is black and white, not gray, then it's a very clear handoff between teams.
Totally agree. And I remember when I was a product manager a long time ago in the field, watching sales reps try and explain how to code for something. I was kind of like, oh my gosh.
Oh no.
kind of tell when someone's sort of winging it, and it's not a place where you want to wing it. It's a place to get conversation to the experts.
Agreed. So let me talk a little bit about what reimbursement support programs are. I'm pretty sure most people on this call knew this, but just in case. Essentially what we provide, what these programs are, is patient access service to help navigate coverage on a case-by-case basis. So typically these are new innovative technologies that either have no coverage or negative coverage when they launch onto the market. So FDA approval, FDA clearance, that's great. Now you've got to get through this gauntlet of, I don't have any coverage, therefore there is literally nobody who's going to use your technology because they know it's not going to get covered for each individual patient. So the goal here is to help patients access the service in the short term where there's this sort of coverage black hole until policy can be established, and also to help establish policy. So if you keep the technology in front of the payers, if you're putting pressure on them to think about coverage for it for each individual patient, ultimately the goal is to get them to establish medical policy. And I think the other thing that's important about these programs is, at least for us, we have a very clear distinction between when something's not covered, experimental, investigational, not medically necessary, and when it starts to become covered, we basically draw the line and say, okay, it's now covered. We are no longer supporting that payer's cases because they cover it. That goes back to the provider. That's a standard, prior authorization. You take it. This is meant to be for patients who literally can't access the technology. So we make that distinction very clear. And I think that's important for anti-kickback, et cetera.
Yeah.
So we're providing that bridge between patients who need this technology, providers who want to provide it, and payers who don't want to pay for it to make sure that the patients can get access. That support can include anything from benefit verification, prior authorization, all the way through external appeals. And I'll talk a little more about what external appeals are. And that can start at any process, at any point in the process, sorry. The provider can do the prior authorization, hand it off to us. They can try doing a peer-to-peer, maybe an internal appeal, hand it off to us. It really doesn't matter where in the process, as long as the provider has already made the decision to get patient access for that treatment. So the other important thing about how sort of I distinguish and have throughout my career between, and I'd love to hear your thoughts on this too, between when an office knows how to do something and doesn't, and why they need us, is when a new technology is first launched and there's maybe not a code, there's not coverage, there's unknown payment, there might be an unlisted code or a category 3 code with no fee schedule. That is not standard of care for them. They don't know how to prior authorize that from the perspective of, they don't know the data behind the technology. They don't know, all of the things that went into the clinical trial. They're not aware of some of the, the important things that we include in our authorizations for a new tech. They're used to doing standard of care prior authorization, something that's already covered, something that's already approved. And so I really draw that distinction between they don't know how to do something versus they do. And we tend to take the cases that they don't know how to do and help them through the process, again, at any point in that process. We take patients in our process on behalf of the patients, not the providers. We work with the providers, but the reason we do this is because we know at some point in this process, there's going to be a prior authorization that's going to get denied. There's going to be an internal appeal or two that will get denied, most likely because it's considered experimental. And then at that point, the patient has a right to an independent review. It's called an external review by an independent review organization. And the reason this is important is because, number one, there's an opportunity to overturn the denial. It's reviewed by an independent reviewer separate from the payer, who's not looking at the payer's policy or lack thereof. They're looking at the actual case. They're reading all the case notes. They're reading all the clinical data about the technology. They're looking at the big picture for this patient only. And every time that case goes to an independent reviewer, it costs the payer money. So not only is it an opportunity to get that case overturned, but whether it is or not, it's going to cost the payer money, and they start to pay attention to the fact that there's now a financial hit every time that's happening. And that's really how we keep the pressure on them to think about coverage for the technology. That is a right that's only for patients. So providers don't have that right. Most patients don't even know they have that right. And it requires patient consent and authorization to represent the patient. So we just go ahead and get the patient consent right up front. We don't require a BAA with the office, and we just take the case on behalf of the patient throughout the whole process. And again, the goal is really to get cases overturned and get policy overturned.
Yeah, Kim, I totally agree with your comments on kind of new technologies. I mean, really, the company is the expert on the technology.
Right.
The provider with a new product, they're not going to have all the clinical data. They're not going to know how it functions and works. And so I do think that's the right balance, is the company is the expert in the product, and providing, sharing that information, they really should be able to kind of help describe that and be involved in that for the benefit of the patient. Mark, were you going to add, or sorry, I can't see anybody. So.
Agreed. It's just very insightful.
Okay. Yeah, so just quickly, and then I'll hand it back over to Kim, but wanted to talk through a little bit kind of the options from a program model perspective. So really there's the option to have, if you want to pursue kind of a reimbursement support program, you could hire a third-party vendor like JDL Access, or you could try to build it in-house. And we'll talk through a little bit of the kind of pros and cons, but really the decision is a business one. Both models can be set up to be compliant with the kind of at least mitigate risk from a compliance perspective with all the laws that we reviewed a few minutes back. Really the risk is going to depend on the structure and how it's operationalized, not necessarily whether it's in-house or with a third party. So just kind of keeping that in mind. With an in-house reimbursement support program, some companies opt for this model because they think they have a little bit more control over kind of the workflows, escalation processes, and maybe a little bit more oversight. On the other hand, this does require hiring and building out an in-house program. So, investing in staffing, training, really beefing up the compliance program and the infrastructures, both from a healthcare compliance like fraud and abuse perspective, but also privacy. You need a lot more, as we talked about, kind of the importance of that separation between commercial and reimbursement, and why that's important. Having an in-house program does require a lot of discipline in terms of having guardrails and kind of separation between those functions. And the company has to kind of be aware and acknowledge that, yes, kind of we could have an in-house program in one kind of side of the building, so to speak. And there'll be stuff that they're doing that cannot be shared necessarily with the sales team or the commercial team. So having that discipline, kind of an understanding of why there's that separation, and kind of being able to respect that separation is important. Because if you set that up and it's kind of weak guardrails in terms of not having separation, that's where you're going to get kind of the higher risk outcomes potentially. If you have an in-house process, you are solely responsible for all of the privacy, security, compliance, and audits, really to make sure that you're operationalizing the program appropriately and not mitigating risks. Like I mentioned, some companies will opt to engage with a third-party reimbursement support hub, as they're called. Some of the benefits with this model would be really being able to leverage external experts and kind of established operations. So like Kim's company, JDL Access, they do this for a lot of different companies. So it's something that they already have expertise in. They're not going to be reinventing the wheel each time. Of course, there's going to be little kind of nuances for the type of product and the program that the company would like to support, but really you're able to kind of have a turnkey third-party solution versus having to kind of build it all in-house. So costs might be something that you'd want to weigh from that perspective. There might be faster implementation timelines, again, because it's more of a turnkey thing. If you think about, you could literally engage a company and have them start doing what you want them to do within a couple weeks or a couple months. Whereas in-house, you're having to find the staff, you're going to have to kind of invent the training, draft the SOPs, kind of get all that stuff completed. So the timeline, may differ. And then obviously, if you have a third party doing it, there's going to be less internal infrastructure needed, at least on the front end. This model requires robust vendor diligence. So, finding the right vendor, doing the diligence to find the right hub that works for you and kind of has the same risk profile or is willing to, do the things that you want them to do. Making sure that your contracts are all in order with that entity, whether, there's going to be ongoing oversights or an audit. We definitely participate and perform audits for third-party reimbursement hubs, and we've also performed audits from a compliance and privacy perspective for in-house programs. So either way, you're gonna, want to have some sort of an oversight mechanism. But really, even if you do use a third-party reimbursement hub, the manufacturer really will still retain accountability for compliance. So even if it's an outsourced function, you want to have, and that is why the oversight piece and the monitoring and the auditing is important. Because when they are, working on your behalf, or you are engaging them to do certain things on your behalf, you're ultimately going to have some responsibility and accountability for that.
Yeah.
So just as I mentioned at the beginning, key takeaway, really both models can be compliant, both work. We've seen companies kind of choose one and then switch to another and kind of switch back. So it is possible. I think really it's looking at your risk tolerance, your risk profile, budgetary constraints, timing constraints, and then, how much flexibility, how much control do you want to have over kind of the workflows and process? And then also, is your company disciplined enough to maintain that separation, to make sure that risk stays low and stays manageable?
Yeah.
And then I'll pass it back over to Kim. Mark, if you have any comments.
I'll make a couple of comments. I see we have 3 questions in the chat too. We might want to hit those, but if you don't mind going back to the previous slide for just a moment, I think, this to me is probably, we have over 100 people in this program now. This is probably one that several of you are thinking like, well, what should I do? Should I build it in-house or hire JDL Access, or there's other, providers out there as well? It's a great question. It's one that I think you really need to take some time to think about. I will say just the speed to market, it takes I can see drawbacks and advantages to each model. Obviously, I think highly of what JDL Access is doing as a co-founder of that company. But to get the machine up and running takes time. You have to go, you need to hire people, you need to have qualified experts. Amanda hit on, is this going to be in a separate part of the company? We audit in-house programs. We also audit third-party vendors. The privacy controls are such that you should have a secure area where these people are working, because they're going to be dealing with PHI all day. And even though you have patient authorization, you still have a duty to keep that information safe. So that's going to mean encrypted ways of communicating, frosted glass, perhaps. Fax machines need to be monitored. Believe it or not, we're still using fax machines in this world. There's a lot that goes into creating a reimbursement hub inside your company. I've literally counseled clients where we've been using a third-party vendor, we've brought it in-house, and as Amanda said, like, I know you've done this well, and then we end up moving it back out of the company, which can be really disruptive. I've seen it work really well in-house as well. It depends on your kind of risk tolerance, because if you don't have the right controls in place and someone overseeing all of this, that's where the risk starts to go up. I mean, we've, as recently as a few months ago, we're auditing third-party reimbursement support. When we asked them for their privacy program about it, they pointed us to their privacy policy on their website, which is not a privacy program. So you really need to get under the fingernails of the people that are providing the support to you to make sure that when, if you ask them about a privacy program, that they have a response, for example, and what other types of controls are in place. So yeah, I think there's again advantages and drawbacks. I would think all of that through, and it's a considerable investment. So it's good to spend some time working with your team on your approach.
I think one of the things that's interesting about creating an internal team that's separate from the rest of the company is the trend toward remote employees. So not only do you have,
Right.
somehow to provide oversight over the whole program, but now your employees are all over the country, working at their own desks in their house, typically at a workstation that may or may not be secure. You're probably not likely to audit them from that perspective. So, there's a lot of ways that we use technology, for example, because a lot of our employees are remote, that we use technology to help bridge that. Using cameras to look at people's spaces periodically, making sure that our technology shuts their computer off if every certain seconds, if they leave it open, making sure they have, a separate room, with a door where they can close things off. Their fax is in the room. They have a shredder where they can shred. So you've got to have all that thought through as well, because most of the time these, either ours or somebody's in-house program, the employees aren't at the company anymore. They're all remote. So it's created a unique kind of challenge with that, and making sure that we're being compliant in this field.
Yeah. Great points. That remote aspect is big. Yeah, you could have all kinds of documents laying all over about people's health with very sensitive information.
Right.
Exactly.
I'm happy to run through these questions quick, and maybe
please.
we'll provide a quick response, and then if you two would like to add, please do. So someone asked, how does the risk profile change if the company continues to provide reimbursement support once a therapy becomes more established? So, when again, these programs are sensitive when we give advice on them. Amanda hit on this earlier, and Kim did as well. Once the pathway, once you have adequate coding coverage payment, once that's secured, then it's time for these types of support programs. You don't want to be providing this any longer to your customer, because then it could be viewed as a kickback. And that sometimes takes 5-10 years. I mean, it can take a really long time. But if you are ultimately, the intent of a support hub is not to be a value add for the customer, or to outsource what they should otherwise have to do. And so that would be my response to that. I don't know if you have anything to add, Amanda and Kim.
Yeah, there was another question kind of along the same lines. Is there a timeline? Is there a point in the market, or based on reimbursement level? I don't think there's a black and white rule for that in terms of like, okay, well, now it's not permissible to support. I think it goes back to the rationale for the program. And if, the company should be revisiting that kind of justification on a regular basis to make sure that that's still accurate. Because I think at some point, Mark, to what you were saying, at some point it would tip the scales. And again, we don't know where that point is just because it's not clear from a legal perspective, but at some point it would tip the scales from patient support. The manufacturer needs to be involved because it's a new product, it's complicated, and they don't, no one else knows more about the product than we do, to, okay, they probably should just be doing, the prior auth just like they do with everything else once it becomes the standard of care, like Kim was saying. So I think, it's gray, but I do think the piece that I wanted to reiterate was just that justification for the program should be revisited to make sure that, that's still the case. If it truly is, novel therapy that, is not getting sufficient coding coverage and payment.
Yeah, I couldn't agree more. Perfectly said.
And it takes a long time. I know, having worked in-house under secondments at some very large companies, we evaluate these risks, and we know that it takes a long time, right? Like, it's not going to be a 6-month assignment.
No, right.
It can be 5 to 10 years. Like, I've literally, because under the roof of the company, you may all be thinking, well, this is better, and this will become the standard of care. And but to the world, the physicians, it obviously takes a really long time to get embedded and to convince these payers to pay for everything, pay for things that is in their best interest to pay. Next question.
I was
Go
just
ahead.
going to say about that, Mark, that I do think that has to be looked at, though, on a case-by-case basis, because there could be a solid reason that something is challenging the coverage on that. Or, for example, we have a lot of clients where, we're able to get them to coverage on their initial indication, and then they broaden the indication, and now we're kind of back to square one. So I think there's compelling reasons to look at it, but in general, once the payer starts covering, we start to cut off our support.
That makes sense. Yeah, you could have, like you said, same implantable can, whatever it may be, new indication, and it's like you're starting over, like you said. The next question is, if the reimbursement team is separate from the compliance function, how much, if at all, do you recommend collaboration between the teams? My response to that would be that there should be a lot of collaboration, and these programs need to be reviewed periodically, and that helps everybody involved to make sure you're on the same page and on the path that's lawful. So I don't know if anyone has.
Yeah, agree. I've always worked very closely with reimbursement, in the compliance function. I think we had standing biweekly meetings just to kind of review if there's anything new or different or weird that we need to kind of keep tabs on. But yeah, I would say often, really often. Yep.
Agreed.
There's also changes in state law around the privacy requirements, and so keeping your compliance and legal teams involved can also keep you abreast of those changes as they evolve. Hopefully someday we'll have a federal law beyond HIPAA that regulates privacy information, but we're kind of dealing with this patchwork quilt for now. Luckily, a lot of the states just look to HIPAA. If you're compliant with HIPAA, you don't have additional requirements. But it's case by case as well. So someone said, when you say sales, quote unquote, do you mean personnel who sell the product or personnel who are on a sales incentive plan? I would say more like tip of the spear sales reps is what I'm thinking there. In most modern companies, everybody's on some sort of bonus plan that is impacted by profitability of the organization. Maybe not if you're a research-based company, but when we say sales, we're really thinking about, I would say, field representatives that are out commission-based selling the product. And Kim or Amanda, if you have anything to add.
Yeah, that's exactly it. I think the further you are removed from that role, I think there might be different kind of risk profiles. But yes, I think when we're talking generally about sales do's and don'ts here, we're talking about, boot on the streets, sales reps.
Yeah.
Agreed. We will flag like bounties or bonuses that are paid for reimbursement success. We don't like that. We're in auditing. Usually like your marketing people are going to be pretty removed. There could be some performance metrics, obviously, with the reimbursement support teams, but I would make those more about MBOs. But yeah. That's a good question. Next one is how long, this one's a little longer. Okay. How long is
That
it
one's, I
appropriate
think
to
we
provide?
addressed, but
Yeah, I think we got this one. Yeah, I think we covered that. The answer to that one is it depends. How long should you provide support? It
Yeah. Depends.
ask your lawyers and your compliance and reimbursement. Next person that asked that actually is a compliance person. So
yes.
The next one, what about nurse navigators? So I think, yeah, I think where that question is maybe, you know, sometimes, a lot of times, especially in these in-house teams, you'll have nurses, social workers, et cetera, that are working on these reimbursement support teams. Oftentimes they have that background by training. I'm not sure exactly about what that question is. What about nurse navigators? Do you know, Kim or
Yeah, I mean, I'm guessing just the topic of nurse navigators. So theoretically, somebody outside the company or within the company that's helping to kind of facilitate patient's journey. So I mean, it depends. It depends on how it's structured, what they'd be doing with reimbursement. I've seen models where they have been able to help maybe gather or collect prior auth documentation.
Yeah.
But yeah, I think it depends on the program and structure and how it's set up.
Agreed.
Yeah, Kim, I don't know. Do you have experience with working with nurse navigators? Kind of that phrase, at least.
No,
how it's
not from
used?
that perspective. But I think when you think about the fact that they're probably seeing PHI, and they probably, excuse me, are, you know, have some kind of agreement in place with the office to be able to do that, that by virtue of that fact, you know, it's fine if they're involved in the process as long as it's not incentivizing the process.
Yeah, I would also make sure they're trained. You know, I remember auditing a program once where I was talking to someone, just like, she had a massive heart and would do anything for these patients, but
yeah,
turned out she's doing a lot, you know, giving them rides, going to their house, things that I'm like, okay,
Yeah.
there needs to be some controls in place so that, you know, people don't get themselves in trouble or get the company in trouble. So
Exactly.
yeah. Okay, that's all our questions. Great questions.
Okay.
Thank you, audience.
Great.
Okay. Yeah, and I think Kim has a few slides here.
Yeah.
On compliant program setup.
Great. I was going to say, I think this is me. I think we've talked about a lot of this. I think having clear policies and procedures in place around anti-kickback and false claims. And by that, I mean working with an organization like Gardner Law, where you're looking at your risk tolerance for your company. And that's whether you have an in-house program or an external program. I think you really want to have very clear guardrails about what payers are you supporting or not supporting. How far in the process do you want to let this go? Some of our clients have us stop after external review. Some want to go, you know, even farther, administrative law judge, for example. It just depends on your own risk tolerance. And I think that's where somebody like Gardner Law is going to be really good about helping you define what that looks like and where you want to establish those guardrails. We have clients that are, you know, kind of all over the map from that perspective, and it's a very individual company by company decision on the amount of risk. Again, keeping a strict separation between commercial and clinical. We've talked about that a lot. PHI protection measures and having HIPAA compliance, having ideally either someone like Gardner Law or an external company, like we use a company called Healthcare Compliance Pros, because Mark was conflicted and not able to help us. Otherwise, we would have used them. But they helped us to establish all of our policies. They helped us to set up the whole program. They help us do all of our internal training. They audit our training program. They audit employees. They, you know, it's soup to nuts in terms of having an external partner who we can then call and ask questions if there's any question about something to do with PHI and privacy. But what I say to everybody, so, you know, we have our own hub, and then we also help companies consult on setting up their own internal hubs because we have the expertise, we may as well share it. And what I say to companies when we're doing that work is just expect that you're going to have a PHI breach. You will have one. No matter what you do, no matter how careful you are, somewhere along the line, something's going to happen. And just plan for it, right? Understand how you're going to handle a breach, understand how a company like yours or like HCP is going to step in and help you with that, what you need to report, when you need to report it, have policies in place around all of that. Because as careful as everyone tries to be somebody, an employee is going to walk away and do something or whatever, there's things that happen in the real world. So having those kinds of measures, and also I think doing kind of a dress rehearsal for that is not a bad idea, because then you know that you're ready and you're protected and you have the things in place that you need. It's super important. Having patient consent and or BAAs, depending on how you want to run your program, either through providers or through patient consent, and making sure that's very transparent to the patient, the provider, everybody. If you use any third-party vendors, so one of the key components of keeping our remote employees, within our bounds, but also making sure that any interactions we have with providers are safeguarded from a security and privacy perspective. We have an IT partner. Now, if you have an in-house program, you might use your own internal IT vendor, your department, or you might have a vendor that you outsource something to, but they are essentially there to help you shut off computers if employees go rogue and start to, take data that you didn't want them to take. They also have training programs. There's lots of reasons to have a strong IT partner for this process. So having BAAs with them, for example, should they have, by chance, going through that process, access PHI for some reason, you want to make sure everybody's protected. So just make sure any third-party vendor you have a BAA. I can't overemphasize the ongoing training for staff, making sure they're being reminded constantly about compliance requirements and privacy, not just annually, but all the time. Making sure that you have audit trails and documentation so that if you are audited or if you do have a breach, you have all of that information handy and readily available. Having escalation procedures, understanding who's going to do what if there is a compliance concern is really important. So having a compliance officer, a security officer, and making sure you know who to go to for anything that happens. And then, of course, regular compliance monitoring and auditing, which I know you do as well, is really important to make sure you're staying on top of everything. How do we enforce compliant sales team interactions? I think one of the keys here is to keep data segregated. So as a general rule, we make sure that any companies that we work with, unless the company says the sales team can have access to PHI, there are a couple exceptions where sales has to have access to PHI, for example, custom design implants. They're involved in that process. So just by virtue of how they interact with the patients for the technology, they already see PHI. In those cases, we can make exceptions. But in general, our rule is sales team should not be seeing any PHI. And you can segregate that in whatever platform you're using to make sure that sales can just see de-identified data. Obviously a one-way referral process. Sales should be referring to reimbursement, never vice versa. You've said this a couple times, Mark and Amanda, no sales compensation tied to anything to do with enrollments. Prohibiting sales from using reimbursement support as inducement, regular training for the sales team as well on appropriate interactions, and then again, technology controls to enforce access. So making sure if there's a password, it only gets you to a certain point in the database, whatever you're using, and that making sure those restrictions are holding. So the way we do that in-house and for our current customers is we have a cloud-based external platform that keeps PHI outside of company infrastructure. And I think, if you are going to have an in-house program, one of the ways to help with your own PHI protection, your own HIPAA protection in-house, is to make sure that you're using a secure cloud-based platform that's external to the company that stores the PHI, so it's not in your own infrastructure. I think that's super helpful to, making sure that when you get audited, everything is separate from what you're doing. So isolating the data, patient data isn't internal to the CRM system. So if you have a Salesforce CRM that you're using, making sure it's separate from your Salesforce CRM, and that those things are isolated. Role-based access control, we can certainly give various controls depending on who has access to PHI within our technology. Any CRM you're using should have audit logging for data access and changes, enforcing separation between sales and patient support functions, obviously, and again, reducing the company's exposure to PHI. In terms of internal support program HIPAA compliance, I've talked about this a little bit, the fact that we have a compliance partner to help us manage this. I'd recommend this highly to anyone. Certainly you can set up your own policies, but I think when they come from an organization like Gardner Law or HCP that does this for a living, it gives me a lot of sense of security to know that we have the right policies in place and they're constantly being updated, because, we can't keep up with all the changes in the law that are happening. So I think that's a key component of that. Again, through our consulting, we can help our clients set up that kind of program, and also help them understand how to mitigate the risks, especially with our remote employees, because that's the way everything's going.
Mm-hmm. All right, I think this is mine. Thanks, Kim, that's very helpful. So just kind of walking through kind of the operational kind of aspects of it. We obviously, Gardner Law can support, all of that, as Kim noted. But yeah, just a little bit further on kind of the clear role separation. Again, we'll have 3 minutes left, so I'll try to wrap this up quickly. Sales team on the left, what's allowed. Reimbursement team on the right, what's allowed. Again, really the ideal state and what we want to encourage and reiterate is that sales can connect, but not control the reimbursement activities. So definitely having a strong partnership and a strong a team, but really knowing kind of your roles and knowing kind of when to phone a friend and pull in either sales or reimbursement. So just kind of staying in your lane. Some common missteps that we see, and I know we have probably way more than this. I could probably go on for another hour with just some real life examples. So what goes wrong? Sales reps could suggest specific codes, the wrong codes, modifying or coaching on medical records or other claims documentation. That's a big risk area, because essentially then you're, falsifying or editing kind of a claims document. Promising coverage or reimbursement outcomes, being too involved in the prior auth or appeal calls with payers, acting as the go-between for payer communications, keeping copies of documents containing PHI, really trying to be very helpful and helping providers complete forms. Again, just why this is risky. This is getting into kind of an inducement territory, False Claims Act exposure. It could be seen as interfering with provider independence, and specifically with kind of interfering in the claims process. And that's where the False Claims Act piece. And it really just doesn't leave a defensible narrative from a compliance perspective, in terms of it should always be going back to the patient access, facilitating patient access. So sales team do's and don'ts: direct providers to the reimbursement support team, so the appropriate person to have the conversations if there's questions. Always use approved scripts, talking points, escalation pathways if issues or concerns arise. Sticking to general education on coverage processes, documenting handoffs appropriately. So sales teams should be well trained and should have materials in hand, approved materials in hand that they can share and provide, high level reimbursement information and education, but then connecting with the reimbursement support team to have those more detailed discussions. So don't recommend codes, modifiers, don't coach or give information, give language examples of what should be in the medical record or on forms. Don't complete or edit medical records. Don't communicate directly with payers about coverage. Don't store or transmit PHI. And kind of wrapping up with don't frame the reimbursement support as being a sales advantage or a sales tool. All right, and then I'm just going to go to kind of key takeaways because we are at time. So in summary, reimbursement support programs are really very critical for patient access, especially with new technology, but they really have to be designed intentionally with compliance at the core. So strict separation between commercial and patient support functions is really one of those foundational compliance expectations. The technology architecture matters, as Kim talked about. There's external platforms, that may reduce risk and enforcement burden. And we can, equip sales teams to work effectively, even if they're not able to see the PHI and they're getting kind of de-identified aggregated data. And putting in place practical guardrails really allows both patient access and compliance. And we've, been very successful in helping companies structure programs that meet their business goals, but also remain, low risk or mitigate risk as much as possible from a compliance perspective. And I know we're at time or overtime already. I think we got to all the questions. I don't know if anyone has any parting thoughts, but.
There are a couple more questions. I know that I see some people drop,
okay.
but a lot are still on the line. Maybe we'll just roll through these quick and
Sure.
Everyone is welcome to follow up with all of us as well if we don't get to your question. This person asked, how do we distinguish between offering reimbursement support as a resource and conduct that would be interpreted as an inducement? I think really, to simplify it, it's about patient access to your technology. So stick to that sort of ethos, and I think that's going to help you. Of course, you should talk with your lawyer and your compliance team to make sure all of your messaging around what you're offering is compliant. But that's kind of my high level view. Did Kim or Amanda, anything you want to add to that?
Nope, well said.
Someone just asked this kind of a question really related to tax. So I'd say call your tax lawyer, but they're saying that ICF language is informing patients that the reimbursements they receive for out-of-pocket expenditures like travel are taxable. So I would talk to your tax lawyer. I remember.
I'm not sure about that one.
Yeah, Man and I passed the bar. Tax was part of it.
It was.
I think,
you want to take tax advice from me.
Yeah, the government wants to tax, I think, everything they can. So it might be considered income. I'm guessing if it's in the contract, it's probably there for a reason. But yeah, we'd ask your tax lawyer. Someone asked, what is a good litmus test for when reimbursement support programs are not needed? And thus, actually, I think I covered that one already. Another person went back to the nurse navigators, just asking if they can be involved in reimbursement. I think they can. You just need to make sure they're trained.
Yep. And on what they're doing.
What they're doing and all the things we're talking about. But I do see a theme in these questions is when you stop providing this support.
Yeah.
I think you need to kind of coordinate with your frankly, your sales, your commercial leads, your sales marketing people. What are they telling you? Talk with your reimbursement team, talk with your lawyers, your compliance folks. It needs to be a collaborative discussion around whether the support is needed. And ultimately listening to the patients and what their experience is like trying to get access to your technology. If it's terrible, then it sounds like you probably still need the support. But that's kind of a high level response to that. I would get consensus among your management team as to when you should cut these off, or at least the people that are close to it, including the lawyers and compliance folks. Because
it's a really good point. We've gotten a lot of questions. I think maybe we'll do a webinar on and include that at some point in the future, kind of factors to consider.
Yeah, for sure. Thank you both for doing this.
Yeah, thank you, Kim. Thanks, Amanda. Do you want to close it, Amanda?
Yeah, just thank you for, taking time to participate. Great questions. Good conversation, Mark and Kim. And again, feel free if you guys have questions after, feel free to reach out. Have a good afternoon.
Thank you. Take care.
Thanks, guys. Bye.